Hello, welcome to today's National Neonatal POCUS Collaborative webinar. I'm Ashley Osborne and I'm going to be your moderator for today. Before we start, just some general housekeeping items to make note of. The chat here is disabled for the audience, but the moderators may send out general announcements via the chat. So please use the Q&A feature to post questions, and we will answer those during the Q&A panel session. This webinar is also being recorded and will be uploaded to the collaborative website, neopocuscollab.com. And now to our main talk. Our guest speaker today is Dr. Yogen Singh. Dr. Yogen Singh is a full professor of pediatrics at the University of California, Davis, and the chair for the European Society of Pediatric and Neonatal Intensive Care, (ESPNEC), Cardiovascular Dynamics Section, and POCUS Working Group. He is passionate about training neonatal and pediatric intensivists in echocardiography and point-of-care ultrasound so that these tools can be widely applied for clinical decision-making in emergency situations. He led the development of the ESPNEC evidence-based POCUS guidelines for use in neonatal and pediatric intensive care units and expert consensus statement on neonatologist-performed echocardiography, training, and accreditation in the UK. He has published extensively in peer-reviewed journals and in textbooks regarding neonatologist-performed echoes, neonatal hemodynamics, and neonatal cardiology. He has spoken at conferences and taught at workshops all over the world. His accomplishments are indeed way too numerous to recount in this short introduction, but needless to say, we are so honored to have him as our featured speaker today. Dr. Singh, please take it away.
Thank you so much, Dr. Osborne, for the kind introduction. And thank you so much, Dr. Lawrence and Dr. Carr, for inviting me to talk on this important topic on the behalf of the National Neonatal POCUS Collaborative. So this topic is very close to my heart. I'm going to talk about the targeted POCUS used for the crashing infant in the NICU. I have no relevant conflict of interest. As Ashley said, I do have training in the comprehensive echocardiography, TNE, hemodynamic evaluation, but today talk will be more focused on the POCUS really, and also towards the safer protocol as the title says. By end of my talk, or maybe by end of the session today, there are three important learning objectives. First one, to learn the importance of using POCUS in the neonatal emergencies. Secondly, to learn a predefined stepwise approach, ultrasound approach, to rapidly identify the common causes in a suddenly decompensated or decompensating infant. Thirdly, to learn how to use the targeted POCUS for a rapid assessment of shock and how to institute the targeted specific intervention. Let's take a step back before we discuss about the POCUS in the NICU. We have come a long way in last 70, 80 years. This is the image of the first ultrasound, which was like 1946 or 75 years back. And then ultrasound became more and more concise and modern. You can still see the really big machine in an ultrasound lab. But as we know today, what we see, machines are really smart. They're getting smaller and smaller. They're getting powerful. They are getting handheld or even the wireless. So these machines have find their way in the mostly in the acute care situations or acute intensive care units. It's not a surprise that ultrasound use has become a really important milestone in the intensive care units, right from the adults to the NICU, because this is non-invasive, this is easily available, it's portable. We can get the information at the bedside in real time. It's visual, it's powerful. You can see, and other people around you, your nurses or the colleagues, trainees, they can see, and you can train them, show them. It empowers us to get the anatomical, physiological, and the hemodynamic information in real time so that we can make a right, accurate decisions. Which I'm really passionate about is in the emergency situations. We know it saves lives. Early recognition of the life-threatening emergencies is really important, and instituting a specific intervention is life-saving. So use of the ultrasound in any form really helps in providing the right intervention for the right patient at the right time with an accurate diagnosis and with a specific timely intervention. With this background that in the emergency situations is really helpful, it has been well adopted in the adults and the children's practice. And you all know that so many protocols are there for the different conditions, like in the trauma, blue protocols, false protocols, SESME. Those protocols are integral to the adults and the children's practice in the ER. But in the neonates, we have been a bit laggard. But so let's look on what happens to the neonates who have the decompensated shock. We know neonates in children with a decompensated shock, they're the poor outcomes. The direct relation is there. If you get too much fluid or too little fluid, this is related to the poor outcome. Similarly, we know persistent hypertension is not good for the long-term neurodevelopmental outcome. Late diagnosis or the inaccurate diagnosis or lack of the understanding of the pathophysiology and delay in the instituting the targeted specific intervention all lead to the poor outcomes. To improve the outcomes, we need to recognize shock and the time critical emergencies early on, and then institute the targeted specific intervention. We all do our PALS and the NRP or the Europe NLS courses, and we all read about the 4H and 4Ts, all about the correctable causes. And these are the time critical emergencies such as hypovolemia, hypoxia, tension pneumothorax, cardiac tamponade, thrombosis, critical CSTs. And we know early treatment, early intervention is definitely can save life and can improve the outcomes. But ask yourself, how many of you can confidently diagnose these H and Ts on the clinical examination on the bedside or the routine bedside monitoring? Just ask yourself, how many times can you get it right for the hypovolemia, for the hypoxia, or for the tamponade, or even the pneumothorax? Let's put into practice really what our colleagues think as well. These are the real case scenarios. We'll start with a simple case, which is pretty common in the NICU setting. This baby was born at 36 weeks by crash section. There was a history of fetal tachycardia with a heart rate of up to 215 beats per minute. And there was a suboptimal fetal monitoring. In fact, there was a loss of fetal movements. OB team did a great job, and so the NICU team as well. But despite all the best efforts, baby had prolonged coding, and baby was starting the treatment of the hypoxic ischemic encephalopathy on the HIE. And the cord blood gases were poor, and so the first blood gas in the NICU as well. So first pH was 6.8 with a very high base excess of -19 and unrecordably high lactate. Team examined the baby, and there's a capillary refill time, CRT is 3 to 4 seconds. Peripheral pulses are weak, and baby looks pale. The mean blood pressure is 17 to 18, which is the non-invasive, because the team is still trying to get the UAC and the UVC umbilical lines. Again, ask yourself, what will you do? Will you give fluid bolus 10 mils per kg? Will you give fluid bolus 20 mils per kg? Start some inotropes, and we can discuss what inotropes as well. Give some sodium bicarbonate to correct the metabolic acidosis, or accept the low blood pressure, saying this will improve with time, and I don't rely on this one, this non-invasive. I'll give you seconds to think. And most of you will give the fluid bolus 10 mils per kilogram. And that's what the team did. But as soon as they started the fluid bolus, baby deteriorated suddenly. There's acute deterioration, and they had to stop the fluid bolus, and actually they have to start the coding again. But let's think about it. How did you make this decision that we should give fluid bolus 10 mils per kg? How did the team make that decision? That's based upon the assumption that babies will respond to the fluid bolus. But the French Starling law doesn't support that. If the cardiac functions are poor, giving a fluid bolus is not going to help. In fact, baby may decompensate. That's what the Frank-Starling law is. It may be based on previous experience or our guidelines, which changing with time, but still a lot of people are using the same traditional guidelines. This decision-making did not take any consideration of the underlying pathophysiology, what's happening with the compensating mechanisms, what's happening with the preload, afterload, or the cardiac contractility. The same baby now comes from the local community hospital to the tertiary unit. After a few hours, after about 4 hours, someone does a very limited POCUS at that point. It's not the best image, but despite not the best quality image, what do you see? It's an apical 4-chamber V. You can see very poor cardiac contractility, and heart is well filled. There's no signs of hypovolemia. The cavities are widened. Look on the left ventricle. You can see it's really nice and open cavity here. And this is the left ventricle here, left atrium, right ventricle. Just if the simple image would have been available on the bedside, just ask yourself, will you get a fluid bolus now? And simple answer is no. So very target POCUS can provide, even if emergency situations, very important information. It will not tell about the cardiac functions, what percentage of ejection fraction is, but for the emergency life-threatening, it will tell the contractility, tell whether you should get fluid bolus or avoid the fluid bolus. Of course, you've got the expertise for the hemodynamic evaluation TNE. You can look on the cardiac outputs and more detailed hemodynamic evaluation, which can be even more helpful. Let's look on the second case. Similar kind of setting. I'm putting the similar cases, but how they look very differently. If you look on the echocardiography. It's a term infant, was admitted in the NICU with a working diagnosis of HIE and the acute pulmonary hypertension, PPHN. Very common scenario in your and my practice. Team did, again, fantastic job to stabilize and institute the intensive care, optimize the cardiorespiratory support in terms of the ventilation, babies on high-frequency oscillatory ventilation, and they tried different mean airway pressures. Is on nitric oxide, 20 parts per million, ppm. Local team, community hospital had started dopamine, and team continued and also added epinephrine and hydrocortisone. There was a suboptimal response with the poor blood gases, high oxygen requirement, baby continued to the metabolic acidosis and the poor perfusion, which is improving. So team had consulted the ECMO, and ECMO team agreed, baby is getting better. Let's get the echocardiography, rule out the critical CSTs, and we'll put on the baby on the ECMO watch. A formal echocardiography by a peds cardiologist showed mildly impaired cardiac functions, moderate to severe acute pulmonary hypertension, and no underlying critical CSDs or congenital heart defects. After a few hours, out of hours, this baby acutely decompensated with very difficult to oxygenate, and baby became hypertensive. And now RTs are handbagging the baby, and we were called in. So again, think yourself, what will you do in this situation? Of course, you look on the, evaluate the baby clinically and look on the tube is in place or not, tube is dislodged or not, tube is obstructed or not, all those things you will do. But beyond that, with the suboptimal response and the acute decompensation, you may think of some options. These are 3 options I put you on the screen. 1, to continue optimizing the cardiorespiratory support because baby was okay for a few hours. This may be mucus plug, do suction, put the baby back on that one. Or call the ECMO team. Already we were concerned about this baby. Baby's already on the ECMO watch, and team knows them, knows the baby, so easy to call them and easy to put on the ECMO. Or phone a friend who can do functional echo, full echo, or at least a limited POCUS. All 3 are very different things, and we can discuss about these things. In this case, I was on call, so we looked on the baby, although I looked at more detailed functional echo, hemodynamic evaluation, but I'll present only the POCUS part today and in this case, how that can be helpful even. Let's look on these two views. On this side, you can see the apical four-chamber view, and you can see the right side of the heart is much bigger. Right ventricle is almost double the size, maybe bigger than the left ventricle. Same with the right atrium is much bigger. In the parietal long axis view, right ventricle is big, is hypertrophied. Interventricular septum is here, and you can see the posterior free wall, which is left ventricular free wall here. But you can see in the parietal long axis view, the interventricular septum and the posterior free wall, they're touching each other. We call it a kissing sign of the left ventricle. And that's a good sign of the hypovolemia. Sometimes with the bad, like significantly hypertrophied right ventricle, interventricular septum may come towards the left posterior wall, but hardly touches. But here you can see it's almost dividing the cavity into two, one towards the apex, one towards the left ventricular outflow tract here. Just on the POCUS images, you can look on the multiple views, maybe at least 3 views: apical four-chamber, parietal long axis view, and the short axis view. We did something. These are the 2 images taken about 30 minutes apart. On the right side here, you can see after intervention, that's the apical, same baby, apical four-chamber view. But look on the parietal long axis view. Does it look different? This is the before the intervention, where you can see these kissings on the left ventricle, but within 30 minutes, this sign is completely gone. The cavity, which was into 2 parts here, is really good left ventricle, good filling now. Right ventricle is still hypertrophied, still is big. So something had changed drastically within 30 minutes here. So what did we do? Just think yourself for a few seconds. It's only 30 minutes really, so that is not a long time, only 30 minutes apart 2 images. So in this case, we give 30 mils per kg of fluid therapy, initially 20 mils per kg, repeat the echo again, and give another 10 mils per kilogram. And after 30 mils, heart is well filled. Now, well-filled left ventricle is telling us there has been significant improvement in the pulmonary venous return. So it means pulmonary blood flow has increased. It means oxygenated blood has come back to the left side of the heart. So it means there'll be a better oxygenation. And the left ventricular cardiac output will increase from the increased end diastolic volume, because contractility is really good here. With a good contractility, we could give this fluid therapy confidently, and we could see this baby improving within few minutes really. Later on, this baby developed a gram-positive positive blood culture, and there was a signs of the sepsis, and this baby had a intravascular hypovolemia secondary to the third space loss. And repeat echo again showed the improvement in the hypovolemia, blood flow, and the pulmonary blood flow in the cardiac output. So you can see these 2 cases. First case highlight, although there was hemodynamic instability and acute decompensation, but with poor contractility, giving a fluid therapy, baby decompensated. On the other hand, in the second case, with acute decompensation, with the contractility is really good, given in the 30 mils per kg fluid therapy, baby not only tolerated very well, baby improved significantly within half an hour. Let's look at the third case. This is again not uncommon. We do see 1 or 2 cases every year in in the big units. This is a preterm baby, extremely preterm, who was born at 27 weeks, IUGR baby, initially did very well, was on the ventilated, given surfactant, then extubated, was on CPAP. But after a few days, baby started to have desaturations and bradycardias, those episodes of desats and bradys. And then nurses said this baby doesn't look good, desats, bradys, and then there was sudden decompensation with a very low heart rate, up to 40 beats per minute, and saturations were almost untraceable, like it's only 20s. 2 attending neonatologists were present in the unit, and they started the coding, and it was a high quality coding, extensive coding. And you can see on the screen, they threw up everything on this baby: 2 doses of epinephrine, saline bolus, 10 mils per kg. Even they give one dose of sodium bicarbonate, and O negative blood. Baby looked very pale by this time. And they continued the coding, high quality coding, continued for 15 minutes. Again, question for you to think, what shall we do now? So this baby is already got the 15 minutes of the chest compressions and good quality coding with all those medications. Shall we stop the coding or shall we continue? And you continue how long for? What else you will do? If you want some more help. If you want further help, who you'll call and what you'll ask for? And some of you might be thinking this is a definitely POCUS talk and let's call a cardiologist. But calling a cardiologist will take good 15, 20 minutes for the cardiologist to come even when they're in the hospital. If you call even your colleague, that may take a few minutes. But this is a really life-threatening situation with the coding going on here. So when we looked on this baby, soon after a couple of minutes after this, when decided to call for the help, so POCUS was done at 20 minutes into the coding. When we reached there, at that point, there was no pneumothorax. When you did ask, the PIC line, central line was in a good position the last X-ray. But on examination, heartbeat was hard to hear. But that's what you see in the POCUS. There's a subcostal view. And you can see here is a large halo around the heart. There's a large pericardial effusion. There's a cardiac tamponade. We say tamponade because it has led to sudden increase in the pressure in the pericardial cavity, leading to complete right atrial collapse, complete right ventricle collapse. So there's no systemic venous return coming back to the right side of the heart because it cannot enter the heart because the high pressures, sudden increase in the pressure in the pericardial cavity. And you can see on the echo here that chest compressions are going on. Yes, it's a poor quality image, but it's during the coding, but this makes the diagnosis even in a very fraction of seconds really. So what will you do now? How many of you have done the pericardial centesis? Just ask yourself what will you do. Again, if you do blindly, many people worry where the needle will go. Many experienced people have done in the past. They will say, yes, they can do. But ultrasound guided is so much easier as well. So in this case, subcostal approach, again, keeping the probe there and just under the probe between 30 and 45 degree angle with the needle towards the left shoulder. You can see the end and this needle coming into the pericardial cavity here. And we aspirate like a tip-in kind of fluid. And you can see still coding is going on. We never stop coding. Coding is still going on, but now we can see the tamponade pericardial fluid is gone. Right atrium is now better filled. And you can see the blood is coming back to the right atrium. Even the left ventricle looks better here, and the cardiac output returns. And I got more images showing the cardiac output here is much better now. So this case highlights really that immediate availability of the POCUS not only is really helpful in diagnosing a time-critical emergency, but also helps in safely performing intervention, like in this case, pericardiocentesis. This baby not only improved, but was discharged home. We had a similar second case as well with the excellent outcome because POCUS expertise were available, the POCUS machine was ready there. And that raised a question in everybody's mind, definitely in mine. Should POCUS be a part of the resuscitation protocols, especially for the infants not responding to the routine measures as we follow the NRP and LS guidelines? Just a thought. I know it's not possible at the moment, but just a thought, shall we think of the POCUS in those situations where with the extensive coding going on, babies not responding? Let's look on these three scenarios. With the first case, what you saw is a classical after 5-7 days, or even after longer duration as well. Often baby do have some kind of central line, either PIC line or the UVC, and they suddenly decompensate. Initially maybe decess bradys, and they gradually get worse and sudden decompensation with the cardiac tamponade. These are three cases. You can see in the first side where the video clip is moving. On the left-hand side, you can see here, this is a tamponade water case we discussed. In the second case, here team thought of the tamponade, but they could never see, they could never diagnose because this POCUS was performed by a person who was not trained, and even the machine was not good for even the good quality. Third team never thought of the tamponade, and sadly, second and third case both had a poor outcome. They died. In the third case, team never thought of the tamponade. They thought, no, it's not the tamponade, but this baby in the autopsy had the tamponade as well. So that highlights the importance of the right good training. Although POCUS can be learned fast as compared to full echocardiography or the TNE, but still it needs good quality training, still need longer training. It needs better recognition. So it's not that people can just attend a course and start doing it. Otherwise, in the second case might happen easily, that in this case, you may not see anything. Like in this case, I can't even play the video because I can't even see what was there. It's a still image, but autopsy had showed the cardiac tamponade was there. So you can see all three babies had the same condition, cardiac tamponade, all were preterms, all had the central lines, and all had the tamponade. Case where we had a good POCUS expertise, we had a machine available, and person who could detect early, excellent outcome. Second, third case, we had bad outcomes, and we definitely want to avoid that one. And that's probably one of the most important use of the POCUS in the NICU or PICU settings. So through these three cases, I highlighted these three time-critical life-threatening emergencies, which need not only rapid diagnosis, but also the accurate diagnosis. All they need different, immediate, specific, targeted intervention. Although all may have the hypertension, all may have different, similar kind of hemodynamic instability, but the intervention may be very different. Like the adults who have got the already ultrasound-based protocols for those life-threatening emergencies, even the children, we do have the EFAST protocol, and different protocols are there. But in the neonates, until a couple of years back, we had no such ultrasound-based protocols. Now we have published two ultrasound-based protocols. One is called SAFER protocol. That's the sonographic assessment of the life-threatening conditions, and it's a revised protocol. R comes from there, from SAFE to SAFER, and the crashing neonate protocol. Today, I will focus, in the next few minutes, I'll focus on the SAFER protocol. It's a very simple, simplified approach, really. Simple one probe approach where rapidly we either rule in, we diagnose a condition, or we rule out, or we just rule out that condition, really. It's a standardized ultrasound-based approach in order of urgency and priority. What does that mean? What it means really depends on depending on the treatable cause. We diagnose those conditions in a term of priority. Can you treat that condition? Can that save the life? So it describes 6 steps. You can see the 1, 2, 3, and up to 6 steps are there. But when I talk about this one, when I apply in my practice, I normally look on the 7 steps. And first step I call step 0. And that's a ground zero rule, really. But before even we apply this in the practice, the 2 really important messages are here. One, if the baby is already collapsed and you are coding going on, it should not interfere with the coding steps, really. Secondly, this is not the time for teaching and training. We love teaching and training, but this is a time where the most experienced person get the images within few seconds. And these don't take time. I'll show those images can be performed very, very fast. So step 0, that's the ground zero rule, where we look on the cardiac contractility and the cardiac filling. We are not looking at the cardiac functions objectively here. We are looking just by eyeballing. Are the cardiac functions good or bad? Like the 2 cases I showed you earlier, can I give fluid bolus confidently and safely, or shall I avoid a fluid bolus? If you see this kind of like with a good contractility, not a problem. You can give fluid bolus 10, 20 mils per kg, even more. And with the Frank-Starling law, curve really should improve the cardiac output. On the second hand, on the second case here with the really poor contractility, globular looking left ventricle, dilated left ventricle, you want to avoid the fluid therapy here. You want to avoid the fluid bolus. And if you see these cardiac functions, there's something seriously wrong with this baby and will need an urgent echo. You avoid the fluid therapy. In this case, or the cautious, start some right inotropes, and in that case, call some urgent help who can look on these cardiac functions, why baby has poor cardiac functions. So it can help into asking for help early, whether baby needs urgent echo or not. Similarly, is the heart well filled or not? Like in this case here with the well-filled heart, you can see the interventricular septum, free wall, nice left ventricular cavity, end diastolic volume is pretty good, and systolic volume is good here. And this baby had no problem with the cardiac filling as compared to this case, second case, which is we discussed really. Then we go to the step 1. These are the level. Let's go to the 6 steps of this safe protocol, how we implement this stepwise approach with predefined sets. Step 1 is for the detection, rapid detection of the cardiac tamponade. Just for comparison, again, this is not the lecture for the teaching how to perform this imaging, this more showing the how they look really. On this image, you can see there's a subcostal leverage here, right atrium, left atrium. There's no halo, black halo around the heart here, as compared to this case, what we discussed, cardiac tamponade here. Once you see the right atrial, right ventricle wall collapse, that means this baby is in serious problem and needs urgent pericardiocentesis. If there's no right atrial, right wall collapse, in this case, that baby can wait for a person who can perform a more detailed assessment of the pericardial effusion, can differentiate, look for the causes. But if you see the cardiac tamponade, you don't have that time. In that case, baby need intervention now. So you can rule out, if there's no cardiac tamponade, then you go to the next step, second common, which treatable emergency, the pneumothorax. You can very rapidly diagnose the pneumothorax. Our babies are lying down in the cots and in the incubators. You just, in that case, air rises, and with the same probe, you can put on the in the anterior of the chest. You can look on the lungs on the lung image here. On the top, there's the pleura here, and you can see the A lines, B lines. Once you see this pleura, what we call lung sliding or margic ends, there's a lung sliding, the B lines, all they rule out the pneumothorax in that particular area, and all pneumothorax will be anteriorly. As compared to this case here, pleura is not moving, and you see so many A lines but no B line. So absence of lung sliding, a lot of A lines, and no B line. And if you're lucky, if the pneumothorax is not very large, small, you can see the lung point. Again, we can discuss later on in the discussion how to look for those. Those will diagnose the pneumothorax. Again, you can look on the X-ray, but X-ray may take time. In some settings, it may come within few minutes, but we know everywhere X-ray is not easily available. It may take few minutes, maybe 10 minutes, even in some good busy units as well. But ultrasound takes few seconds. If there is no pneumothorax, in that case, look for the other causes which can lead to acute decompensation. It can be in the babies with the high drops, can be a complication of the central line or PIC lines as well. We can look for the pleural effusion. Again, rapidly we can diagnose the pleural effusion. Is present or not? Is it large or small? Does it need urgent drainage or not? That's the whole point is here. Fourthly, we have put this one here. Again, if there is an easy accessibility to echocardiography and the TME, in this case, they should be looking on the heart problems at all. But if you see an aorta, which is not pulsatile at all, you can't feel the femoral pulses, aorta which is not pulsatile, that may be because cardiac output is so low. This baby is in serious problem, like the baby with the cardiac tamponade or the very poor cardiac contractility. There's no blood flow, significant blood flow in the peripheral pulses, or it can be underlying heart defect. Again, to highlight here, POCUS is not for screening for the critical congenital heart disease. It's not to establish. We are not looking at the heart in details. Here, we're looking on the very specific questions, really. If you see a very nice pulsatile aorta, it cannot diagnose or rule out the coarctation. But completely non-pulsatile aorta may suggest, if you see that one, you can start the baby in the high dose of prostatin, call for urgent help. Again, this will warrant an urgent echocardiography, urgent peds cardiology consult. So in these situations, POCUS can help in getting the right help early. Then we can go to step 5 and 6, looking on the large ascites. Again, some babies, the high drops are after NEC, after perforation, they may be difficult to oxygenate, difficult to ventilate, and they may need urgent paracentesis as well. Similarly, large interventricular bleed, again, POCUS is not to diagnose those in fine details, but is the baby has got a grade 3, grade 4 large bleed or not? Can this baby could have caused collapse from there or not? Shall I ask for a formal brain ultrasound now, middle of the night, to make the decision what shall we do, or can this wait until morning? So those can help in those situations as well. So these are the 6 steps of the approach, but let's take again step back. If you've got a baby who is acutely decompensating or acutely decompensated, often these babies are well babies, they're making some progress, or typically preterms with the central lines or the PPCHN babies. What are the acute, those babies? It is sudden acute decompensation. The first, obviously, the important is we had to see the baby. Urgent clinical evaluation is really important. We need to be thorough. We need to be meticulous evaluation because a lot you can diagnose clinical there. And we have done it past. POCUS is not a magic bullet. We had to get a good good practice here. We need to look on the dope. Again, does our EG tube is in place or not? Is obstructed or not? Is dislodged? And pneumothorax there or not? And again, our equipment is working or not. Sometimes the machinery failure, into the pump failure, ventilator failure, and also the central line positions as well. Can we look on the x-rays? Can we do the x-ray faster, or can we do the POCUS faster? So make the decision which can help in making the decision faster. So what are the modality you adopt really? Key is to get a urgent rapid diagnosis here. But we use the safer protocol for evaluation here, which is designed to help the physicians, clinicians to make a rapid rule in, rule out diagnosis. So in this case, you can either make a positive diagnosis. Here you got a specific diagnosis, step in, rule in, rule out, what we discussed. And you find those life-threatening conditions, we can target our intervention and we can do the ultrasound guided intervention. But if we don't find those conditions, that's equally important. That's a negative screening. The safer protocol is more like a screening tool for the life-threatening conditions. In this case, we can a negative screening, then you move on. Then you look on the other causes of the acute decompensation. Revisit, is your tube still in place or not, dope and those one, and also look for the other causes. Is the baby is septic? Is the septic shock? Has the baby got critical congenital heart defect? Shall I call a peds cardiologist now? Is the baby any metabolic underlying problems or endocrine problems? Other causes, what you all know really. So even the negative screening is equally important, powerful. That's this safer approach become really powerful tool for the life-threatening emergencies. So to summarize, to take home messages, targeted POCUS. Again, we are using the POCUS in a stepwise standardized lung points here. Targeted POCUS is an excellent tool for the screening the life-threatening emergency situations, especially in the NICU. Also for the central line complications, typically for the cardiac tamponade, for the pleural effusion, those can be easily picked up. But the other conditions, what we discussed, like the pneumothorax, interventricular hemorrhage, or the ascites, those can be easily picked up as well. SAFER is designed in a way that is a rule in, rule out using single probe. That means really it can be done very, very, very fast. It does not take you a few minutes to perform the full assessment because you're looking only a few images here. With the experienced hands, it can be done very, very fast. And once you pick up a life-threatening conditions, in that case, you can institute a targeted specific intervention. Something has come in the red here. One, again, I'm emphasizing here, use of the POCUS should not and maybe must not interfere with the standard resuscitation protocols, what we follow for the NRP and what we follow for the like NLS in the Europe as well. So those protocols, we should not deviate from those protocols, and POCUS should be adjunct to the clinical examination, adjunct to those research protocols. And most of these when we perform very, very fast, and when you're mostly subcostally, but you do over the chest, when you're taking the break in between, when checking the heart rate, checking this, then you do very, very fast, really. But do not stop the coding for the performing the POCUS. The other important point is know the limitation of the POCUS. POCUS is very limited training, but a limited scope of practice as well. Whether it's cardiac POCUS or the other non-cardiac POCUS. It is not a screening tool for the critical congenital heart defects, and you cannot diagnose the heart defects. It's not designed for those ones. That need comprehensive training to start, say, normal, abnormal, maybe on the TNE or NP, or diagnose a full heart defects, let's say, in the domain of the peds cardiologist completely. Again, full comprehensive hemodynamic evaluation is out of the scope of the POCUS. That's why today what we discussed really is more what we can do very fast in the rapid assessment of the shock or the life-threatening situations. Before I stop, I'll highlight this important quotation which come from our book really, Seeing is Believing. But your eyes will see only what your brain knows. And that's why you look at this triangle here. Knowledge and experience are really important because we can teach anybody to how to acquire the POCUS images. But what does that mean? How you implement those images in your clinical practice? You need knowledge, you need experience. And if you want to read more about this one, you can read, feel free to go on our book or go on our website, which is the simulator, which helps you in getting a lot of experience hands-on because we need that one too. I'll stop it here and I'll be happy to take any questions during the panel discussion.
Thank you, Dr. Singh, for such a wonderful and engaging talk. We're now going to move to our Q&A expert panel discussion. Please put any questions into the Q&A and then I will relay them to the panelists. And so joining Dr. Singh today, we have Doctors Belinda Chan, Virginie Malpetit, and Cecile Tizot. Dr. Belinda Chan is an attending neonatologist, associate chief, and medical director at the University of Utah. She is also adjunct faculty at the University of Utah Hospital Radiology Department. She has been the founder and director of neonatal POCUS programs at various institutions since 2018. Dr. Virginie Malpetit is a senior neonatologist with extensive experience in pediatric and neonatal intensive care in Paris and London. She is a key advocate of neonatal lung ultrasound in the UK and holds accreditation as a mentor by the British Intensive Care Society. She co-founded the NeoFocus UK group and leads the French group for pediatric lung ultrasound. She emphasizes a holistic physiology-based approach to patient care, and her publications on heart, central lines, and lung ultrasound contribute to advancing individualized care by integrating clinical data with POCUS findings. And finally, Dr. Cecile Tizot is a pediatric and fetal cardiologist in Geneva, Switzerland. She is the head of the echocardiography laboratory at the Children's Hospital of Geneva, chair of the Swiss Society of Pediatric Cardiology, founder of the SNCC POCUS Working Group, and board member of the Swiss Pediatric POCUS and Targeted Neonatal Echocardiography programs. She has a special interest in cardiac POCUS and has taught cardiac ultrasound for neonatologists and pediatric intensivists. So I'm going to kick it off with a question for Dr. Singh. What differentiates the SAFER protocol from other protocols? And can you highlight for us the specific benefits? And also if you have a probe that you would recommend people use.
Thank you, Ashley. That's a really important question, really. So the key protocols are there. Two I showed today. One is the SAFER protocol. One is the CNP protocol. SAFER protocol is designed for the patient in the NICU, typically for the screening for the complication of the lung lines, whatever the complications are. This is a very simplified approach. You can use a single probe. You can use in emergency. You can use any probe. Given the choice, maybe a curved small probe, 8C probe, 8 to 12. That curve may be better. We can look on all the organs very easily, including the brain, ascites, and everything. If you don't use a curved probe, you can use any probe. It can be a cardiac phasal probe, 12S or even the 6S will do really. So any probe will do in emergency, but given a choice, I'll go for the curved probe. It's different from the CNP protocol because it's a single probe led really and rule in, rule out. CNP is similar protocol. Again, I really like that protocol too. It's developed by the experts all over the world, and it is a little more comprehensive. It extends beyond these 6 steps, really, looking at the recognition of the pulmonary hypertension, recognition of other conditions as well. So SAFERY is very easy to implement and follow. Third one, which I'm not sure, which is not typically the same simplified POCUS protocol, I think that overlaps in the more echocardiography, which that's I didn't show because is a POCUS talk today, is by Ibarra Rios, is more from the Mexico. That protocol is more extensive, and I think that maybe different part of the world need different protocols. It may be great for those institutions, but for the US, for Europe, where the PEDS cardiology, echocardiography, TNE expertise are easily available, we separate the POCUS. That's why CNP and the SAFER is more relevant for my talk on this side. And I think SAFER is much easy to implement.
And Dr. Chan, I know you use a slightly different protocol at your institution. Can you describe how your protocol maybe differs from the SAFER protocol?
Yeah, I think when I started 8 years ago, is before the SAFER was published. So I have to come up with something that works in my head. So I was kind of following the EFAS adult emergency room, where they look for like pneumothorax and right upper and left upper quadrant, and then the pelvic, and then go to subcostal. So I just use that for the neonatal institution, just as something to start with. And then like now you see SAFER protocols, like, oh, that makes more sense for diagnosis. You can do a diagnosis base, differential base versus a system base, like a location base. I think that come into question is what works the best in different institution. And then this will be a question for, that's why it's great to have this panelist. You have US, you have different country, and based on what is available, and then that will change your protocol, especially US is pretty sensitive about cardiac POCUS. And then so with that, we may look for other courses before the cardiac stuff too. And then I also have another question is, I think it kind of go into one of the question in the QA is, Dr. Singh, you mentioned that the step 0 is not to interrupt CLP and resuscitation. How do you integrate your SAFER protocol during the acute resuscitation, chest compression, and other treatment at that time?
Dr. Chen, this is obviously, as we said, really should be done by the most experienced person. So with the like cardiac tamponade, contractility, and cavity filling, all those can be seen subcostally. What you really need to go to the near the chest during the coding, if you are doing the coding, is the pneumothorax. That really takes 2 seconds to put the probe on either side anteriorly. That can be done during the assessments in between, or even during the chest, or you put the probe on this side. Again, ascites, and they can be done easily. It's not designed, it's not a bulletproof that it will pick up all the causes of the acute decompensation in the babies in the NICU. Designed to pick up the most common causes, which can be easily not picked up on the clinical examination otherwise, like the tamponade, hypovolemia, poor contractility. Like sepsis, critical CSDs, they're beyond the scope. They need extensive time. You suspect, you treat them. Like sepsis, you cannot diagnose, rule out on anything. Similarly, critical CSD will take time. So those when you suspect, you start the treatment, like start the prostate, get the specialist help, and those can be stopped later.
And speaking of that difficulty of integrating these kind of protocols in that acute code situation, do you recommend any like time limitations for the person trying to perform it?
Yeah, absolutely, Dr. But there's no evidence of what the times should be. But in my experience, like subcostally, and whole panel will agree, and many experts who are in the audiences, they will agree, tamponade, once you put a probe, seeing the tamponade cannot take more than a couple of seconds. Similarly, seeing the contact lady is hard doing like this or doing like this will not take more than a few seconds. So I'm not looking here minutes even, I'm looking for the image, and you do not have to do all together. Subconsciously what you get, team is doing their job. You're not interfering with the team coding or any of those management. You can do all those, and only time the pneumothorax. Again, pneumothorax, we have been traditionally diagnosing with the cold illumination, with the X-rays. Again, those tools are there too, are there to help us. So this is another adjunct to help us, to empower us in addition to the other tools.
And then I have a question from our audience, and this question is for any of our panelists. Do you have tips for performing an ultrasound-guided pericardiocentesis? For instance, again, questions about what probe selection and then also where to actually place the probe.
I showed the case. I can kick off, and then my colleagues can definitely join in. So again, is the whichever probe you have got, that doesn't matter really. Emergency, this is a time-critical emergency. What I showed really, what we do, and we've done quite a few times in this case, in emergency situations, again, these baby will have the coding. So do not go in the chest really, in this case, subcostally, mark at 3 o'clock, straight on the giphisternum, tilt the probe, look up. And then once you see the tamponade, you visualize the heart, putting the angiocath or long needle angiocath catheter there, going from the subcostally under the probe towards the left shoulder about 30 to 45 degree. And you'll see as soon as the needle is coming in the pericardial cavity, you cannot get it wrong. And people have to do blindly as well. This is the best approach. Of course, you can use the other one, maybe stable large pericardial effusion. You can do the transthoracic one, but that should be left for the more stable patients, stable baby. It should be done by persons more trained, experienced. I'll stop it there, let my colleagues.
I actually have a tidbit, just so that people are aware. Is the preset, when you select the probe is important, but selecting the preset is also very important. If you select a machine that said EFAST preset, the screen marker is actually opposite than the cardiac screen marker. So when you're putting needle, putting procedure, you want to make sure the left and right where the screen marker is relative to your probe marker, because adult integration of these kind of resuscitation protocol, they use the EFAST mode where the screen marker is on the different side. So just be aware when you're doing procedure and looking on the left and right. And then in that protocol, they have a lot more ways of timing to integrating ultrasound with the trauma patient. And then maybe in the future, Dr. Singh can develop something, teaches how to integrate like ultrasound, kind of similar to adult trauma scenario.
Just one comment. These markers are, sorry, Virginie. Markers are really important, but I think one in emergency situation will not in these situations. Really, one of the really nice image I got, that baby was saved, although totally wrong way, but they picked the tamponade, drained it, and it's a wrong side marker. It doesn't matter in those situations, but that's the important point of the chain.
Yes, I do agree. And we need to, because sometimes people are scared. They're scared of is what I'm seeing responsible for the crashing. But we need to remember that these babies are crashing, they're dying. So whatever we see will be the answer to the reason for crashing. And it's not small effusion we're looking for, it's massive effusion, tamponade. So I think putting a needle is such a big fluid amount is not as scary, because anywhere the baby is dying and putting a needle here, it's actually very easy, because you have a massive echogenic area where you put your needle in. And the second thing, I totally agree with Yogen regarding the probe. We did a study with Nadia Youssef to assess the safer protocol, because the first question was, what probe should we use? So we didn't do a very scientific investigation on that, but what caused a good agreement between beginners and expert people that the easiest probe was a semi-convex probe, the one we used for cranial ultrasound. And the reason was we could assess well in terms of depth, as well the heart and the lung, with not too many twinkling with the depth and the gain, and that was the easiest probe. So I think this needs to be validated in future studies, but the first assessment we did was really that the semi-convex probe was the easiest one to use in this specific protocol.
Dr. Tizot, did you have any thoughts?
For the position of the probe, I think wherever you can put your probe and you don't interfere with the CPR, I think it's good. As my colleagues say, it's a huge amount of fluid. So even as a cardiologist, you put the probe wherever you can see, and I think it's okay. But the key point is really not to interfere with the CPR. For the probe, I think for neonates, you always want to take a small probe like a 10 megahertz. But if you have at disposition something like a 6, just remember that you will get deep. You can go deeper. So sometimes it's easier to get good images. So between a 6 and 10, even if a small neonate, I would just use maybe the 6 just to have better picture, especially if the patient is getting CPR.
And how did you all roll out this protocol or a similar type of protocol at your different institutions? For instance, did you start with a core group of people who were able to use it, or was it limited to certain times of the day when certain people were available?
I'm happy to talk about it. Sorry.
Yeah.
So,
Can you start with it?
No, I think it's an amazing protocol because it's very easy to teach, because it's a single probe rule in, rule out. You have very well defined area to scan. I think it's a total spirit of the holistic approach of Daniel Lichtenstein, as Dr. Singh showed us for the 4 blue protocol, Sesame. It's always the same approach of simple and single probe. You rule in route. You need to be a good clinician because you need to know what you're ruling in and what you rule out at each step, not just looking, but you know exactly what you're ruling in. Actually, it's not very basic. It's something very intellectual. You need to know exactly what you're doing at each point. And what I've found is easy to teach. And I tell my trainees, and we did that in the unit, anytime they scan a baby for any other reason, they can do the protocol because it takes maybe less than a minute to do. And just get used on a normal baby doing well to get their brain used to perform this protocol.
Actually, just one comment in addition to Virginie. I completely agree with Virginie. The key point is here to train as many people as possible in the US side, as many providers as possible. Because if you train 3 or 4 people in the POCUS, that's not going to work, because then sometimes they are there, not, it's an inconsistent approach. So this is very simple protocol. You can train maximum people for this emergency skills procedure and get everybody on board in those, and because nobody will disagree that here is plays a really important role. And I think there's no easy answer to how we train everybody. Just it needs support from the divisions, support from the hospital, need resources, and need time. The trainer's time and the trainee's time. Trainers need to spend a lot of time on these courses and training people.
We have many good questions. So we're going to wrap up with a couple final questions. We may go a little bit over. I hope that's all right. What roadblocks did you face when implementing the protocols? Issues with space, staff, buy-in?
I think probably all of them. The first important thing is, like, especially in the US, although we are getting better, most of the NICUs do have the ultrasound machine now. First is the infrastructure, really. Getting the ultrasound machines, getting all the essentials, what comes with the machine, image storage, expertise. Like in some units do not have any POCUS expert, how to start the program, really. And again, National POCUS Collaborative have done a great job giving this platform for the people to discuss about these things, and also helping training people. These kind of webinars or our office hours, all they will help as well. But you need a person, a leader in the department, program director, who's really passionate about it, And then he or she, they need the support from the division, not only for the machines, but also for their time. And then comes the buying in from the other attendings or colleagues, because that's really important. They need to see the value of the POCUS, value of the echo, value of the TNE. Well, what are like end of change? Change is hard. We know that change is hard. And especially here, like if you come with one or two experts in the whole unit, it's even harder. But one thing I can tell you, we all know that it's going to happen. It's coming our way. All of the medical school now, 70-80% medical school are training even the medical students. We know adults adopted. We know the ER is adopted, and it's really changed the practice for the life-threatening emergency situations. Question is really, shall we look on what the challenges are, how to address them, how to embrace this practice and practice, or shall we say, no, we can't do it? Shall we wait really? Wait is probably, you can hide for a little longer, but not for long. It's coming in our way.
And Dr. Tizot, did you have thoughts about how to facilitate a cardiology collaboration, especially for many of us in the US that have that, distinction between TNE and cardiac POCUS?
Yeah, so we have this distinction in most countries in Europe. In Switzerland, we have it. So if you're TNE trained, then you can just evaluate the kid on the neonatal unit for full hemodynamic evaluation. POCUS is a little bit more difficult in Switzerland because it's not still very popular for neonates, because I think people are afraid that you're going too far. I always say that you need to keep people willing to do POCUS and confident. And I think even though you get not so good picture, whatever you're going to see for the kid is going to make the kid better and improve the outcome. And I think we're talking a lot about POCUS right now in webinar from medical people and people that are trained, but in 10, 20 years, we'll just talk about it in medical school, because all the students are going to use the probe the same as they use their stethoscope. It's just a matter of time. And I'm totally convinced about that.
And then
Just
this
one comment.
will be, go ahead. Go ahead.
Sorry, Ashley. I completely agree with Cecile, and this is really critical for any country, that we need to define the scope of the practice very clearly. Like echocardiography, all the congenital heart diseases, first echo, they are in the domain of the peds cardiologist really, and that they should be done by them, because there are tons of experience we need, and that has to work in their collaboration with the POCUS or TNE. We have to with the collaboration of the peds cardiologist really. With a TNE, you need 12-month long time to train. Again, those are for it's a protocol-based comprehensive evaluation, but the POCUS is very limited training here. So we need to know the indications, and knowing the limitations is really, really important. And we always say, and every single talk, we always talk about this, is do not ask too much from the POCUS, especially the cardiac, even the non-cardiac. Otherwise, you'll make a mistake, your program will go many years back. So we need to stay within the scope of the practice and indications. That's really important.
I think that's the same with the stethoscope. You can have cardiologists say, I hear mitral insufficiency, and you can get a medical student saying, I just hear a murmur. We still use the same thing. We just have a different experience to do different diagnoses. And I'm sure echo and ultrasound is going to become to that point where you're just going to be able to use it for specific things that everybody can use. And then you will have different level of training and different expertise, and like the same we use for many things in medicine.
And that's a great note to end on. We're over time, but thank you for everyone for joining us. And thank you to Dr. Singh and all our panelists for this wonderful discussion. In the chat, you will see that there's a link to the Neo POCUS Club website, where you can find this webinar along with all of our other prior webinars. And we hope to see you at our next webinar next month. Thank you all.
Thank you so much for joining us.
Thank you.
Thank you so much.